All right. Good evening, everybody. My name is Tim McMahon. I'm the Director of Marketing here at St. Joseph Hospital. And tonight I am joined by Dr. Munoz from Manchester Urology. So thank you for joining us, Dr. Munoz.
Happy to be here. Good evening, everyone.
So I'll give a quick introduction, and then I'm going to let Dr. Munoz tell you a little bit more about himself and his practice. But Dr. Munoz received his medical degree from the University of Pennsylvania and completed his residency in urology at Dartmouth-Hitchcock Medical Center. He is board certified in urology and has been associated with Manchester Urology Associates since 2002. He's currently the president with Manchester Urology Associates, with locations in Manchester, Nashua, Dover, Derry, Portsmouth, and Monadnock. Dr. Munoz, which we'll talk about a little bit more in a few minutes here, is renowned for his work with the DaVinci robotic system and has traveled the United States instructing urologists to use the DaVinci robotic system. So again, the purpose of tonight's broadcast is to not only introduce our audience to Dr. Munoz and Manchester Urology, but also to answer some of the most common questions that we hear around urology, and certainly to get your insights and let our audience ask questions as well. So if anybody watching has questions that they would like the doctor to answer, please post it in the chat box below, and we'll actually see those real time. And if assuming we have time, Dr. Munoz will answer those the best he can. So, Dr. Munoz, aside from what I just read on your bio, is there anything else you'd like to tell our audience about yourself before we get started?
No, I think that was a nice summary. Part of Manchester Urology, I've been down in the community for 20 years. I spent 7 years up in Lebanon, so I feel like I'm a New Englander. I grew up in West Virginia, so kind of similar terrain, but definitely a much more vibrant culture up here for sure. But I think the thing that Manchester Urology brings to Nashua and to St. Joe's is we've kind of merged with the current urology program down there, and we're hoping to bring in a lot of the specialties practices that Manchester Urology can provide to a community, and particularly to St. Joe's, from everything that pretty much encompasses most of urological practice and care that is needed in the community.
Great. So just so I know, just so our patients and our audience members know right off the bat, if someone has a urologic concern, something they want to get checked out, how do they get in touch with you? Do they go through their primary care? Do they call you directly? What's the process?
Yeah, I think we get a little bit of both. As you know, a lot of this may be dependent on insurance plans and referral-based patterns, but we have offices, as you mentioned already. We currently have an office at 17 Riverside in Nashua, or in Manchester as well, and several of the other communities. But we have a active website that's fairly interactive that can help you through the process of getting in to see us, or from a primary care referral. We have a very aggressive referral pattern system here in our office, so we try to triage those as quickly as possible, because most of the people that need urological services are usually symptomatic, whether it be a kidney stone, a urinary tract infection, blood in their urine. We appreciate the level of urgency and concern that people and patients have about that, and we try to get people in as quickly as possible.
Great. So with that in mind, actually, so what are some of the most common issues you treat? What are the common things that people are calling you for?
Yeah, so we tend to treat most of the urological issues relate to the kidneys, the ureters, bladder, or prostate. So any symptom from kidney stones, urinary incontinence, blood in your urine, difficulty in voiding are pretty much the most common spectrum of what we manage from a urological practice. There are a lot of medical or urological malignancies that we deal with, but those tend not to be as symptomatic as some other things that are non-malignant. And probably by far, we see a lot of kidney stones, and probably more commonly since we've all got to enjoy wearing the masks. And I do feel that people aren't drinking as much with the masks on because they just don't have the opportunity to. So I think that that's really probably the number one diagnosis that we see most commonly with symptomatic people.
No kidding. So just for folks who've never had kidney stones, what are some of those common symptoms to watch out for? How do you know if you have kidney stones?
Yeah, most people know it. A lot of women say it's worse than pregnancy, so or delivery. Oftentimes it's associated pain on the side or what we call the flank. People can have blood in their urine, but they often have significant flank pain with nausea. Those are the classic symptoms for kidney stones, and it's usually colicky, meaning comes and goes, and it can be very, very debilitating.
Oh, wow. Okay. And so I think it's very interesting that you said you're seeing more of it right now because people are wearing masks and they're not drinking as much. So is that what causes? I mean, what's kind of the general cause of a kidney stone?
Yeah, the most common causes are, well, the most common stones are calcium oxalate, and calcium oxalate can crystallize in the urine at higher concentrations. And situations that do that are higher concentration of urine, meaning you're dehydrated, you're not drinking enough. So those particles have a tendency to crystallize faster. High oxalate diets. Dunkin' Donuts is a huge part of society up here, and coffee has a very high oxalate content. So that can contribute a lot to the formation of kidney stones. People think that calcium may be a culprit, but it really isn't. It's really more of the kind of ancillary dietary patterns that affect people: dehydration, high oxalate intakes, high salt intakes, which can increase calcium excretion in the urine. Those are the main culprits to why people form the most common kinds of stones.
All right, so that's good to know. So kidney stones run on Dunkin's. That's
That's not scientifically proven here, but I think it's rolling.
We're gonna get a phone call from Dunkin' Donuts saying we do not cause kidney stones.
I'm hoping to get a gift card from them.
Yeah. but it's certainly good to know. And is that something you see in all ages? Is there a certain demographic that you see that more or less in?
There are risk factors, but most of the time it's not common to see in younger children. But adults, there are certain metabolic situations where people are more prone to kidney stones, obesity. There are certain genetic associated risk factors. So there are these familial tendencies for people that have stones. Commonly we'll ask them, their parents will have them. So there are several oxalate hereditary patterns that people can develop stones from. So yeah, there are certain classes of people that get it. But oftentimes, not everybody's immune to stones, that's for sure. Particularly if you have a bad dietary pattern, you are more prone to them.
And generally, what's the treatment?
So if they are small, you can pass them. So there are certain medications that we can give to help facilitate the passage of the stone. If they don't, and people remain symptomatic, then it often requires an outpatient surgical procedure to endoscopically remove the stone, break it up with a laser. There are multiple techniques depending on the size and complexity of the stone burden. So there are some stones that are not the common ones. For example, uric acid, which can be associated with individuals that have gout, high uric acid levels. Those actually, you can redissolve those in the urinary tract if you can adjust the volume and concentration of urine and the pH of the urine. There are medical ways of reducing those stone burdens.
Okay, great. Thank you. That's a lot of great information about kidney stones. So moving on, aside from kidney stones, you mentioned you deal a lot with, prostate issues. And certainly we hear a lot about prostate cancer these days. Can you tell us a little bit about, what are some common symptoms that we see with folks who may have prostate cancer?
Yeah, so a lot of the early stage prostate cancers, like other cancers, are usually picked up by screening techniques. So normally that involves a blood test for what we call a PSA, or prostate specific antigen. It's a protein secreted by prostate cells. And if those numbers are elevated, is one of the kind of earlier indicators to identify individuals at higher risk. A lot of controversy of that lab test. It's a good test. It's not a great test. There are a lot of other options out there that would be discussed in that screening process, but that's been kind of the forefront of screening over the past 25 to 30 years. Examination of the prostate by what we call a digital rectal exam can feel the prostate gland. And if nodularities are appreciated, that would raise our level of suspicion. So screening techniques are probably the forefront of trying to find early prostate cancer that is potentially treatable and potentially curable at that point. When individuals develop symptoms from prostate cancer, like other cancers, it's often spread or it's caused symptoms associated with either bone pain, which is a common location of prostate cancer spread, or local growth that is affecting an individual's ability to pull or an individual's ability to void for men. So when you look at men, by far, most men that complain of problems urinating, it's usually because of benign changes to the prostate gland, by far more commonly than cancerous changes. But that's something that we're always analyzing when individuals come in with men having difficulty in urinating. We are always in the back of our mind concerned about prostate cancer, and we'll do the appropriate testing if needed.
So, is there, at what age should a person come in to get assessed? I mean, assuming they have no symptoms, to get screened.
Yeah, so there's been a lot of discussions over the years about what's the appropriate screening for this, just similar to kind of colonoscopy and how they've modified their plans, just like breast cancer surveillance as well. Right now, the key age range for individuals being screened for prostate cancer is between the age of 55 and 69. The rationale for that is that if individuals are healthy and they have a longer life expectancy, 15 years or so, which is in that age range, that's the key group of people that should be screened to identify risk. Prostate cancer, there's aggressive cancers, but there's also the majority of them tend to be slower growing. So that's where that window of kind of life expectancy plays an important role in who should be screened. So when individuals get older, if they did develop prostate cancer, statistically, they're going to probably die of some other cause, heart disease, another malignancy. So we have to weigh what we do when we're trying to figure out who the best person is to screen. We have to look at all of these variables involved with that individual, how healthy they are, do they have medical problems, what their life expectancy is, what their family history is. If they have prostate cancer history in their family or other malignancies, for example, prostate cancer, pancreatic cancer, breast cancer, melanomas, then we have to be concerned about those individuals of having some genetic abnormality that could make them more prone to having prostate cancer and more aggressive prostate cancer. But if you look at the kind of the blanket statement by most of the institutions and organizations that look at prostate cancer screening, 55 to 69 is the key population that we should be looking at that would benefit from not only identifying prostate cancer, but treating them in order to extend their life expectancy and quality of life because of the risk of the prostate cancer in those individuals.
Right. So someone who's 40 and otherwise healthy and doesn't have any symptoms and maybe doesn't have any family history, that person probably should not be getting screened or wouldn't qualify for it.
Correct. Unless there was some really significant family history.
Right.
There's some data with chemical exposures, right? So the veterans they've looked at Agent Orange exposure. There's a lot of data coming out with firefighters now with respect to those chemical exposures they have from burning contaminants. There's not a true guideline recommendation, from our institution or from the FDA on screening at that age range, but it's a conversation that you need to have to start having with people in their 40s, mainly because they need to be screened for other things as well, cardiac issues, and just general health issues that you kind of trying to get those individuals that are in their 40s to start thinking about preventative health as they get older.
Sure. No, like I said, I'm going to stop drinking Dunkin's.
No, moderation, have a glass of water with
it. Great. Well, so aside from these, one of the things we mentioned at the opening here was your work with the DaVinci robot. And, for folks who don't know what the DaVinci robot system is and why you would need it or why you would use it, can you give us some background information on what it is, what it treats and how you use it?
Sure. So the DaVinci robotic system is a technological advanced system that's used for minimally invasive surgery. So it's a control response system that allows surgeons to use these instruments through tiny incisions that can do the dissection that could be done open, but just less invasively. There's a little bit of a misnomer. It's not really a robot. It doesn't really have autonomy to it. The system is a very complex control response system. So the technology advancements in this is absolutely amazing, from the visualization component of it, giving three-dimensional viewing, to the dexterity of the instrumentations that allows, at least from our standpoint in urology, to expand the utilization of this type of instrument, particularly when you're talking about cancer surgeries, specifically prostate cancer. The prostate is tucked way down in the pelvis of a guy. It's really hard to get to. This system over the past 20 years has revolutionized the ability to approach that in a more standardized system. It hasn't radically changed the procedure itself and what is done, either via an open technique or a laparoscopic technique. The robotic instrumentation just kind of standardizes the ability for us to do this in the vast variability of an individual's pelvic anatomy. So it gives surgeons stability and consistency in an approach that I do feel makes a significant difference in how their outcomes are and how they recover. We've expanded that utilization into minimally invasive techniques for bladder cancers, for kidney cancers, for ureteral obstruction tumors that would require a very large incision. Now we can do those through very, very small incisions, counting up to 4 to 6 incisions. So people recover quicker. It's just a nice opportunity that we have this technology available at this institution to have that ability to offer that to people.
Yeah, that's fantastic. So that's the type of tool you'll be able to use here at St. Joe's, correct?
Yes. Yes.
That's great. And you mentioned the outcomes, but also the recovery period. So, without the use of this system, was recovery typically a longer process for patients?
Yeah, so there have been a lot of studies that look at recovery in this, and in skilled hands, they're somewhat similar, but with open procedures, your limitations of activities were up to 6 weeks. With minimally invasive techniques using this system, it's cut in half to 3 weeks. Our ability to kind of do the surgery and reconnect things, for example, how long a catheter may need to stay in an individual to drain the urine, has been reduced significantly by probably 50%. And the use of narcotics, the use of transfusions have become almost non-existent. Most people that have this procedure done, for example, for prostate cancer surgery, out of the hospital in a day, usually don't use narcotics at home.
And that's kind of one of the biggest things too, right? The ability to not have to use narcotics and opioids for pain management, right?
Exactly. From the standpoint of even using them, but also from the recovery standpoint, reduction in bowel function, slowing up, all of that. There's significant benefits in limiting that exposure.
Well, that's fantastic. Thank you. So we're coming up in the last minute and a half here of our broadcast. The couple of questions that have come in here. Some folks were wondering about incontinence after pregnancy being common, and how often do you see women postpartum?
Yeah, so incontinence after pregnancy is really secondary to stretching of the pelvic floor. So one of the common techniques with this is pelvic floor exercise techniques to strengthen up the pelvic floor muscles. It's called Kegels. A lot of women will do that after pregnancy. It tends to help that recovery very effectively. And even as women get older, it is one of the frontline therapies for urinary stress incontinence as women age. Multiple factors can play into that for women, including how many children they've had with vaginal deliveries and that kind of recurrent stretching of the pelvic floor, what their estrogen status is, et cetera. But pelvic floor therapy is really a frontline therapy. Beyond that, urinary incontinence in women can be treated with several other factors. It all depends on kind of the workup that we need to do to make sure that there's not associated symptoms of either urinary instability. So those are kind of things that we need to iron out. But there are multiple techniques that we can treat successfully urinary incontinence in women as they get older. But in pregnancy, probably the frontline therapy is pelvic floor therapy. There are well-qualified pelvic floor therapists in the community, and Kegel exercises are frontline therapy for that.
Great, thank you. Well, you know what? I think we just hit our 20-minute mark, and I want to, I appreciate your time, and I want to respect your time for sure, because I know it's been a long day. But again, is there any final thoughts you'd like to share with our viewers about your practice and what you're offering in the greater Nashville community?
Yeah, I think that we really are committed to establish a well diversified program in Nashua. We've been down there now for about 4 or 5 months. We find the community very welcoming from the hospital standpoint. The patients have been excellent. And our ultimate goal in Manchester Urology is to provide the highest quality of urological care within the community. And we want to hire people in our group that have the ability to provide complex urological care right there at the facility, in order to make sure that it's a community-based program, right? Family members can be there to help support in recovery, be there through the surgery. And that's what we really are trying to establish down there. And once we are there and integrated into the community, then there's ownership in those patients that really need our care. And it becomes more of a community family feel than kind of the big box store feel that some places have.
Absolutely. Well, thank you again, Dr. Munoz. And as a reminder to our viewers, tonight we are interviewing Dr. Munoz from Manchester Urology, who is now practicing right here in Nashville as well as his other locations. And we look forward to continuing to work with you in the future. So thank you again. Have a great night. And thank you, everybody, for watching.
Tim, thank you again.
Of course.